Thanks for Lynn's introduction. Can you see my screen?
Yes.
Okay, I'm Yu Zhang from Chang Memorial Hospital and the Chang Medical Education Research Center in Taiwan. This is my honor to share my research about bringing transparency to supervisor conceptualization of entrustment and factor influencing entrustment decision. We used the QMS study to explore. The background is a clinical educator. Sometimes it's very difficult to make a judgment. The resident is sufficiently well prepared for unsupervised patient care. Even some study consider CBME assessment tool can help, but it still raised the lingering question how to best assess the competency of the trainee, how to develop their evaluating judgment, so-called quality of the service in workplace. So the current research on entrustment decision indicate that entrustment decisions are context specific and also influenced by various factors, suggesting that the path of entrustment is very complicated. So in implementing CBME in Taiwan, we set research question about how do EP conceptualize the entrustment and what factor influence their decision. Also, we can obtain some information about the impact of transparency in evaluated judgment. Taiwan has been recognized as an international hub of ACGME regional faculty development, which make the result might be transferable to other contexts. This is our multi-year research blueprint. We use the qualitative data to understand the tension of implemented CBME. Also, we use the Q study to understand the entrustment decision or feedback receptivity. We use the standard method like Delphi to run to construct the Q set and also one-by-one Q sorting activity with participants receive the post-sorting interview. There are 31 clinical educators. We call the emergency physician across the 12 hospital were included. This is the conceptual framework of the entrustment decision-making process, including resident character, supervisor character, their relationship, and also the task risk they perceive. The result, we do factor analysis, find 4 viewpoints. Totally 29 participant account for this. This is the statistic data. And for the viewpoint, we have the consensus discussed to name. I will let you know why this come out. This is viewpoint 1. Very interesting is contextual performance is most important. In ED context, they should respond very quick in timely manner and they can adapt to the change of the treatment plan. Of course, for the attending physician, when patient acuity is high, they will take care by themselves. They will not assign to the resident. So they expect the resident can make little error or no error in the workplace. Of course, how they disposition of the patient is more highly considered. This is an example quote. The overall clinical skill, competency, and knowledge highlight in the workplace, and also the timely response. The second viewpoint is talking about philosophy and attitude on teaching and learning. Both the resident and the attending physician are enrolled in this concept. For attending physician should consider their educational philosophy. But if the resident doesn't have the good response to the coach in workplace, maybe in the future the supervisor will change his attitude or philosophy. So this is also educational issue. And the third viewpoint, also an educational issue, but is more practical in workplace. It means what is the meaningful interrelationship between teacher and the learner in the ED workplace? So it focuses on the competency assessment and evaluation, and also highlight the educational responsibility, because the resident has already engaged in the department and work together with the clinical teacher. So they are the future for the department. So this is a teaching responsibility is more important. The next one is very interesting, is about the moral value. Yeah. Although there are only 2 participants account for this consensus, but they demonstrate the honesty and the humility is very important. And also they're talking about the empathy of the label. If they have this kind of the character, they were willing to seek help because they cannot see the patient get worse. So very interesting is the attending physician also reflect themselves. Their level of competency can afford the coach or their understanding or knowledge about the disease. They are able to do that or not. So this is also the moral value-based healthcare. Yeah, this is example quotes. So we found resident display contextual competency appropriately, and the level of risk for patient care predominant their decision making about entrustment in the supervision label. And the level of their educational interactivity in the workplace also value and high. Although the minority of viewpoint about entrustment, the moral character about evaluating judgment, because they're talking about the do no harm and the patient care, patient-centered care. The consulting interview disclosed the transparency in community-based medical education. So, yeah, so this the 4 aspect point of view is the major outcome we found in our research. So, mostly it can help the clinical educator become more aware about how they to coach the learner and to protect the patient safety when implementing supervision and entrustment standard in clinical setting. Yeah, this is my acknowledge. Thank you.
Thanks, everyone. Just following on the theme, as you said, we were interested in the relationships between feedback, action planning and engagement, and this time in the workplace-based assessment tasks, so similar with what we were just hearing about before. And I have my partners in crime here, and I really acknowledge the hard work that we've done with them as well. I also acknowledge the traditional owners of the lands on which we meet. We're all quite familiar with the problems that we have, and students are confronted with their clinical placements. They have to engineer ways to procure actionable feedback, and we've heard that term before earlier this morning, and to enable them to develop self-monitoring skills. So what we've been doing in our Doctor of Medicine program here, where we have a fairly large number of students in years 3 and 4 that are full-time in their clinical placements, and most of the data I'm showing you relates to what we were looking at in 2021, where students are completing workplace-based assessment tasks, which are mini-KECs, histories, examinations, management. So they're short observed episodes with their supervisors, and procedural skills as well. And so students are collecting this information through a mobile app. They have to get feedback from their supervisors, but then we also ask students to identify action plans related to that feedback. So we had some questions like everybody has with our research. We were interested in the relationship between the feedback and the action plans. We wondered about assessor position, whether that had any influence. And we also wondered if students who actually got actionable feedback had higher engagement in workplace-based assessment tasks as well. So the first thing we had to do was to come up with a way to try and evaluate the feedback. So there was a few of us looking at that. We created a coding framework, the usual discussion. We looked at our reliability, and we were particularly interested in looking at whether the feedback had instructional elements to it, but more so whether there was any element of extension of their learning. And this is an example of something that we would have rated quite low, and we had a score from 0 to 3 for 3, so a score on each one of those components. And here's an example of what a supervisor feedback that we would have rated quite well. And you can see there's sometimes it wasn't a particularly long amount of feedback, but it was more about whether there was some instructional element or an element that helped the student to know what to do next. And we did a similar thing with the student action plans that they wrote. And I think not sure if I mentioned before, we didn't evaluate all 10,000 entries. We sampled across the semester. So what did we find out? First of all, answering some of our questions, what I want you to focus on here is the colours, and particularly the lime green. And you can see the pattern is similar for our procedural skills as well as our mini KECs. And so on the x-axis, we've got high quality feedback is that 3 over on that right-hand side. And that was a proportion of those that had high quality feedback that had high quality action plans. So there most certainly was a relationship between the type of feedback students have got and what they wrote down for their actions. We also had a look at the supervisor levels, and I haven't put that slide in here, but there was no difference between our different types of supervisors, more senior doctors, junior doctors, and of course it's very much worth noting our audience here that many of our students were getting feedback from a very wide variety of health professionals, which is of course not surprising. So we wondered whether students who received actionable feedback had higher engagement. And you can see here that's about as little, no significant difference on this scatter plot. But what we also started to look at was students that were doing more than their required numbers of WBAs, as opposed, which is the green, students that were doing just enough, and those students that really weren't actually engaging fully. And we had a look at the pattern across the whole semester. And you can see here that we had our red lower engagement students that tended to start off a little bit slower and then did this big surge at the end of the year, the end of the semester, because they weren't meeting their requirements, which is not very helpful for a consistent learning. Whereas our higher achievers doing more tended to go across the whole semester. And we've looked at some more recent data, looking at the cumulative event here. So this is actually last year's data across the whole year. And the thing that's important here is that while students might actually meet their so-called targets, the students that tended not to, there was a divergence early on in the year. So we think it's very important to be thinking about what we're doing early on in their program. So some of our research questions, and I'll get on to what does that mean. We do think that feedback leads to good action plans. Assessor roles perhaps not so important. I'm not saying that it's not important, but and that cramming isn't good for feedback. So this idea that we wanted to get students to think more about thinking about persistent practice and higher engagement across the whole year. So where does this lead us? And you might have seen before David Bowden and Liz Malloy's feedback Mark II model, where we've got an event, workplace-based assessment event. Usually students get, or learners have others judge their work and then they plan for more work. But some of the work and then they go on to their next event. But there's a lot we don't know, and we're looking much more closely about the whole process, and we're redesigning all our workplace-based assessments to have a better understanding of where you go from one event to the next, but also what's happening within that event. And we now ask students to judge their own performance, to focus what sort of feedback they want, and to make some comparisons to what they're hearing from their supervisors. And as we've heard from our first presentation, we're spending quite a lot of time looking at how we design workplace-based assessment and also developing our assessment literacy. And the other thing we're doing with our the feedback is we've now doing some more data mining, and we're sharing other students, the quality feedback. So we're able to extract out and give students many more examples of what good quality feedback with action planning actually looks like. So that's our story, and we've got a lot more to learn. Thank you.
Good afternoon, everyone. This redesign of assessments for relevance and inclusivity was a collaboration between myself as a unit coordinator and Sarah Humphreys as an educational designer and expert in universal design for learning, and later on with the students as well. So a bit of background, our bachelor degrees in the discipline of exercise and sports science are a 3-year exercise science degree and a 4-year exercise physiology degree, and both of these have 2 placements in the 3rd year of the degree. They also have a core nutrition unit. When the courses were revised and begun in 2020, the 2nd year iteration of the nutrition unit became a 3rd year unit in running from 2022. The changes that I'm about to describe weren't necessarily planned all the way from the start. They were iterative over 4 years, and that was, I guess, precipitated by a few different factors, including that change from a 2nd to a 3rd year unit, student feedback, and the increased academic integrity risk with exams from COVID-19. So this infographic is a bit of an overview of the assessment changes, and you'll see the very first change was a redistribution of marks from the final exam to continuous assessment in online quizzes. But what we'll focus on today is the changes that were made from the 2nd year unit to it becoming a 3rd year unit in 2022. And in summary, there was a change from a final exam to a major case study report incorporating choice between sports and athletes for the students, which was built where the skills were built on from a minor case study presentation earlier in the semester, where the students were provided with choice between different health conditions. And that assessment replaced a less relevant assessment, a critical appraisal assessment. So the new course was undergoing accreditation, and I had to make sure that the design in the new assessments and rubrics actually met accreditation standards, and so they were mapped against the new assessment. From there, I actually sought help from Sarah, the design consultant, and we worked with a UDL, the UDL as a framework to identify strategy and implementation of the solution. Sarah actually stepped me through identifying the learners, the learning barriers, and the goals for the changes. And that really helped me to fine-tune and articulate my thinking in the assessment changes.
Thanks, Janelle. So in a nutshell, the Universal Design for Learning framework is about reframing our thinking, as Janelle just described, so that essentially we can design for students in the margins rather than for the average student. We can identify barriers that exist in the learning environment, not in the student, and we can offer firm goals, but flexible means for students to achieve those goals. If you do a single click, Janelle, if we want to take a deeper dive into UDL, the UDL framework is made up of 31 checkpoints, and these are suggestions to guide us, and that's what Janelle and I did. So the first 2 checkpoints here really capture the decision we made to offer authentic case studies and giving students the opportunity to apply their clinical judgment. So that supports students in how they engage and how they can make sense of information. If you can do another. The next 2 checkpoints, 7.1 and 4.1, capture the way we were able to offer students some choice and control over what they could choose as part of their major case study. And in a more recent iteration, how students had the opportunity to choose whether or not they would present a report in written format or in oral format. And one last click. And the final 3 checkpoints, they really capture the work we did on revising the rubric to ensure that there was greater clarity in the descriptions of the expected learning, and also reorganizing the order of the rubric so that, excuse me, we started with descriptions of the highest achievement in the first column. So really setting an expectation is this is where we want everybody to be with their learning. And if you want to know more about the UDL guidelines, there's a link at the bottom of the slide. Thanks, Janelle.
So we sought feedback from the students during the semester and at the end of the semester, the first time it was run. And that's how the students and the staff became co-designers in the assessments. Our feedback was fairly good, from the students indicating that we had hit the mark in terms of level and relevance in terms of their placement and their future practice. And peer feedback indicated that we had used a student-focused approach and an inclusive approach. Our quantitative feedback was also fairly good. You can see, I'll just focus on the red and the blue bars here from our unit of study survey, comparing the the third year iteration to the school average, and I'll orient you to the second year iteration in the green. And I just wanted to highlight these two questions on the challenge in the assessments and the development of critical and analytical skills. And you can see that those improved quite significantly from the second year to the third year unit.
And just to finish off, wanted to sort of capture this journey. Like UDL implementation is a non-linear and iterative process, as Janelle has said. And in this particular case study, we've been able to show those first 3 phases of implementation, explore, prepare, integrate, have had a direct impact on the students enrolled in Janelle's unit. But this project has started to scale. So there are more colleagues within the Faculty of Health and Medicine who are implementing UDL. And now also in response to our strategic plan, Janelle's work is influencing our Designing for Diversity project. And one of those initiatives is to look at how we can transform assessment and feedback practices. Thank you.